Today I'll talk about epidemiological study designs. For designing a study, first we need to define our problem. Then we pen down our aims and objectives. We review the literature extensively and we formulate a hypothesis. Then a detailed methodology is designed, data is collected, presented, and analyzed, and conclusion is drawn with extrapolation of our findings. Then detailed methodology definition is, of population under study is clearly defined. Then the nature of study is written. Sample size is determined, which should be adequate and unbiased. And identification of method for sample collection is next step, and followed by writing up of detailed protocol for study. So epidemiological studies can be either observational or experimental. Observational studies can be analytical and descriptive. Descriptive studies include case reports, case series, cross-sectional study, and ecological study. Analytical studies include case control study and cohort study. I have separate lecture for case control and cohort studies. Experimental studies include single blind, double blind, and triple blind experimental studies, which are also known as randomized controlled trials. So descriptive studies examine pattern of disease. Analytical studies are used basically to identify cause of disease, and experimental studies are used to compare treatment modalities. So epidemiological study aim to assess the cause of disease, and most epidemiological studies are by nature observational rather than experimental. Bradford Hill criteria are used as a framework to assess causal association, which includes strength of association, consistency, specificity, temporal sequence, biological gradient, biological plausibility, coherence, experimental evidence, and analogy. There are various sources of error in epidemiological studies, which include random error, biases, confounding. Confounding is the distortion of association between an exposure and outcome by an extraneous third variable, which is known as confounder. So, confounder affect the association between exposure and outcome. The other source of error include effect modification. So effect modification occur when the magnitude of effect of exposure on an outcome differ depending on the level of third variable. So this is in effect modification. A third variable affect the magnitude of effect of exposure on the health outcome, and then comes reverse causation. It describes the event where the defined outcome actually result in a change in the defined exposure. For example, C-reactive protein association with cardiovascular disease risk. So in cardiovascular disease, atherosclerosis is an inflammatory condition. It modifies the C-reactive protein. So when we assess the C-reactive protein and with cardiovascular outcome, then there is reverse causation in the study. So how we tackle these sources of error? For random error, it can be reduced by large sample size and replication study design. Bias can be reduced by simply by being careful while designing our study. Confounding can be controlled by randomization, restriction, matching, stratification, and multivariable analysis. Effect modification can be assessed by stratification for various levels of potential confounders and multivariate analysis. Reverse causation can be assessed by Mendelian randomization. We need to write our study report, which can be written in following headings: title, abstract, introduction, review of literature, materials and methods, results and observation, discussion, conclusion, acknowledgement, references, and appendices.